Hello.
Hey, Roger, how are you?
Hey, how are you?
Good, thank you. Thank you for introducing Mike today.
Sure, my pleasure. Did you get the email about what's it, Gene Carrigy from Stanford?
Yeah, I did. Yeah, poor guy. We'll definitely reach back out to reschedule him.
Yeah, man, it's terrible. Huh?
Awful, awful.
And the reason he canceled was because he had a car accident. He got hit by a car on a bike.
Oh my gosh.
That's why he canceled originally, I think.
Yeah, I remember that he was in the hospital.
Yeah.
What terrible luck.
Yeah,
Would you like him to be in person, or I don't know for sure, but I think at some point in the fall it'll open up.
yeah, I think that would be great. He's a great guy.
Okay. All right.
What's his Mike's talk is again on? I'm just trying to. You sent me the email.
Yeah. Yeah, so his talk topic is cervical spinal cord mapping and paired simulation, spinal cord associative plasticity. So he'll be on any minute. So Roger, once he's on, feel free to get started whenever it's convenient for you.
Sure. Do we have a cutoff for how many people?
You know, I usually try to wait for at least like 20 people. And then get started. You know, I don't usually go much past 7:45. A few minutes maybe.
We got some visitors from Asia, huh?
Yeah. Hey, Mike.
Is that from?
Hey, good morning, everyone.
China. Yep.
Mike?
Morning.
Mike,
you want to share your screen?
Yeah, I'm going to try to do that right now. Let's see. We got a couple monitors here. It's always the big decision here. So what do we got? Desktop one. Yeah, that's what we want to share.
Mike has a very fancy audiovisual setup in his office that I'm very envious of.
I know.
Multiple screens and professional microphones and.
Can you guys see this?
Yeah, that looks good, Mike.
Which one are you seeing, the presenter view, or are you seeing the?
I think it's the normal view.
I see the presenter. I
You
mean,
see
the real view. I mean, the for the audience.
You do see it as one. It's one. Yeah. Okay. Great. Perfect. Let me see if I can bring up my pointer here. So Rupa, you start the recording, or are we recording?
Yep, I'm recording.
All right, it's we have 16. Maybe wait a few more seconds and then. All right, maybe we'll get started now. So it's my great pleasure to introduce this morning Michael Virk. As most of you, of course, know, Michael Virk is one of our spine surgeons here. He's assistant professor of neurological surgery at Weill Cornell Medicine. He did his residency here. Mike is originally actually from the West Coast, from San Francisco, where he grew up. He did his undergraduate at Ithaca at Cornell, and then proceeded to do his MD PhD at Oregon Health Science University on the West Coast, where he did work on neurophysiology during his PhD thesis. He then came back to the East Coast, became a neurosurgery resident, obviously with us, and did his research work in Paul Greenberg's lab at Rockefeller, where he also worked actually in neurophysiology on synaptic plasticity. So he's got a long track record really working on spinal cord related issues. And then I assume because of the strong internal mentorship, he decided to actually pursue a career in clinical spine surgery as well. So he went back to San Francisco, did a fantastic fellowship with Praveen Mumanemi at UCSF and Dean Chow and all the other surgeons who are doing fantastic.
You could try hard not to yell at you?
Yeah.
What were you doing?
I think everybody should.
Oh.
So it's great to have Mike obviously here today to talk about the work that he's been doing for the last 3 or 4 years with Jason Carmel, who's now at Columbia. He's a PhD. And Mike's going to talk to us a little bit about the background and the plans that he has in terms of pursuing this work and hopefully where this will bring us. It obviously fits in great with our ox-spine integration here. And Mike is also very instrumental in pushing that ahead. So Mike is going to talk about cervical spinal cord mapping and paired stimulation. Mike, thanks a lot, and we're really looking forward to your presentation.
Roger, thanks so much for the kind introduction. Actually, this project started. Can everybody hear me all right?
Yeah.
Okay, great. So this project, we kind of laid down some of the foundation for it when I was a 6 here. Roger, you probably remember Dr. Stieg was talking to Raj Ratan up at Virk, and we took a field trip up there and really sat down with a bunch of the scientists up there to talk about the different projects they were doing with spinal cord injured patients. And that's how I met Jason Carmel, who's now one of my partners on this undertaking. So it was a long time ago that we met, sat down, and started kind of just kicking ideas around. And there wasn't a whole lot going on with respect to some of the ideas that we were entertaining at that time. But then in 2018 and 2019, there was really a flurry of activity, some really interesting papers, very high profile papers published in Nature Medicine, Nature, the New England Journal, with respect to epidural electrical stimulation, which is what Jason's interested in. This where my interests overlapped with his with respect to electrophysiology. And these papers really were somewhat groundbreaking that they were with humans. Now, all of these 3 in particular in these groups who are really the people who have been in this field for a long time, they're very senior established labs. We're looking primarily at motor function and ambulation with respect to electrical stimulation. Cervical spine, and when we talk about cervical spine, the big picture here, the goal is really to restore hand function. That's a lot of if you survey people with spinal cord injuries, myelopathy, it's really loss of hand function, and part of that, of course, is sensory. Part of it is motor, but the restoration of motor function in the hands, in particular, is really one of the goals here, and that has been addressed in a couple of different ways. So these papers are largely focused on transcutaneous electrical stimulation. So transcutaneous is really putting on pads, right? Different pads over the spinal cord, over the head. You can use it's in the category of non-invasive stimulation, of which transcranial magnetic stimulation is also a part of. And that's really activating motor circuits, pairing them with remaining non-injured spinal circuits, usually even in complete spinal cord injuries, of course, save transections, but there are some residual functional circuits in the spinal cord, even in severe spinal cord injuries, and really activating these to restore some motor function. So before we get started, I just want to talk a little bit about the background, because this is the first time I've really talked about this in any significant capacity outside of our group. And I just wanted to touch base on a couple of the foundational papers, publications, some of the data that's helped inform and guide some of our experiments. This is a paper by the Capogrosso and Massera group. This is from 2013, and basically, this was a modeling paper. It was primarily using computational models, but also live rat models to look at the effects and to model how epidural stimulation, or at least dorsal-based epidural stimulation, may be working. And specifically, they were looking at current flow using models of current flow. So if you, the caption here in A, pull up my pointer here, whoops. So this figure over here, this represents where the epidural stimulation is taking place. The arrows are representing the vector of current flow and the magnitude, as well as the density. And you can see how quickly this falls off. This particular pulse was at 600 microamps. This was just enough to evoke a motor response. And based on the combination of computational, so computer-based models, as well as experimental data, basically showed that the current is really shunted through the cerebrospinal fluid. That's where current's flowing. It really does not penetrate white and gray matter at these lower intensity stimulations. Okay, so it's shunted into the cerebrospinal fluid, where it certainly hits the dorsal and ventral roots, but it really doesn't stimulate dendrites and cell bodies directly. So if you do this pulse and you're looking down deep into the gray matter at the different lamina and where interneurons and cell bodies are, we really don't see much by way of depolarization, whereas you do see motor neuron depolarization. But what's interesting about that is that you see a 1A. So this is a sensory afferent coming through the dorsal root entry zone. You see this synaptic event down here, and then you see the action potential, or the depolarization of the motor neuron. So the conclusion from this is really that there is a significant component when you're doing dorsal epidural stimulation of afferent activation that is contributing to the motor neuron activation. And they went through and further characterized this with some really nice in vivo experiments, that epidural stimulation is really, there's a high segmental specificity with respect to where you're going to be able to stimulate motor neurons. And that when you recruit the afferents, it's specifically these large diameter afferents. So the 1A and 1B, the large diameter afferents are the ones that you're probably stimulating when you stimulate dorsally. And that the motor neuron response, it can be characterized into early, medium, and late. Early is probably part of a direct stimulation of the motor afferent, but then these larger components with respect to area under the curve, if that's what you're measuring as a measurement of amplitude, is really related to stimulation of the afferent. And they can knock this out and see the effects on the motor response. So here's a paper that Jason put out based on an experiment that is also largely guided a lot of our interest in humans. And in this paper, it is a very similar setup to what we do when we're doing experiments. So this is a rat model, and essentially he's using transcortical electrical stimulation. So exactly what we're doing over the motor cortex. This is used to activate the corticospinal tract, and then to pair that with an electrical stimulation delivered in the epidural compartment on the spinal cord. Now, specifically in the rat, he's looking at the C5-6 level and the biceps femoris. So that's what he's measuring output on. That's where he's measuring his motor evoked potential. Okay, so the experiment is to pair cranial stimulation with epidural spinal stimulation and measure what the effect is on the motor response. And there were 3 very interesting findings. There's more than that, but we'll just focus on these 3. That the pairing of cranial and spinal stimulation has an effect on the motor response. That is, it augments the motor response. Okay, it makes it larger, and it matters how you do this. Okay, so if you're delivering you can change where you're delivering the epidural component, the spinal epidural component, such that you're on the contralateral dorsal root entry zone. And while you do see some potentiation there, it's bigger if you move to the midline to deliver it. And it's even larger, and most significantly larger, at the ipsilateral dorsal root entry zone. So cranial stimulation delivered with paired with ipsilateral dorsal root entry zone stimulation at the level of the cord has the most significant effect on augmenting the response that's measured in muscle. Okay. The other important part is that there is a timing component. Okay, so the latency between the brain and spinal stimulation is very important. So you can deliver the spinal stimulation before the brain stimulation, and we still see some augmentation. So this is the percent of response had there been no spinal stimulation, so just the transcranial response. But if these converge right at about a 10 millisecond interval, so the spinal stimulation arrives 10 milliseconds after the cortical stimulation, that is where we see the most significant degree of MEP augmentation. Okay, so even if they're delivered simultaneously, we really don't see the same magnitude of effect. And interestingly, importantly, if you measure the spinal potential, so when the transcranial stimulation arrives at the spine, it's about 9.3 milliseconds. So when these converge in a time-locked fashion, they have the largest impact. And then finally, if you do repetitive pairing, so if you do this pairing for 5 minutes, and then you go back and measure just the transcranial stimulation, and you compare that to the baseline before the pairing, you see significant augmentation, but this augmentation has a durable effect. So at 10 minutes, 20, 30, and 40 minutes, we see that the effect the effect is sustained well after the pairing took place. Simultaneously, if you just look at delivering a epidural spinal cord stimulation, the threshold is lowered significantly, and it's done. And this occurs in a very highly correlated manner. Okay, so this is just looking at the way that the MEP and the cortical delivered MEP and the spinal cord, the decrease in the threshold, what their relationship is, and this is highly correlated. Okay, suggesting that the effect is occurring at the level of the cord. So with these findings in hand, we set off to do a very similar experiment in humans to look at how, whether or not we can pair transcranial and spinal cord stimulation in humans to augment motor responses. And when we started looking into the details of this, we realized that we really didn't have an amplifier that was capable of this. The Cadwell amplifiers that we use have a lot of capability, but the ones that we have here initially didn't have this capability. There was really only one other company making amplifiers that we needed to get the time lock relationship in place. Nihon Kodak was one of them, and we spoke with them for a while. So we had a lot of work to do with respect to just obtaining the hardware. And in the meantime, we started thinking, well, when we were working through planning some of these experiments, there's not a lot that's been done just to characterize epidural spinal cord stimulation in humans. So that was really what the starting of the mapping. The mapping was really not an initial goal, but what we realized was we needed to have a lot more information before we even started doing any sort of pairing experiments. This really, there's not a lot of information on this. So this is what we started doing, and the gaps in knowledge are very fundamental to the goals that we had in planning these experiments. So this is just with respect, this has no pairing involved. This is just cervical cord epidural electrical stimulation. And so the first goal here was to define the regional specificity. So what happens when you stimulate medially versus laterally on the posterior cord? What about medially and laterally in the anterior cord? So that's just by way of defining the local circuitry. And then with respect to segmental organization, how do our responses change when we're stimulating down at T1 versus C4? Rostral caudal organization of the cord and getting a better understanding of how these myotomes are organized with respect to electrical stimulation. And then to understand the relationship between pathology. So the patients that we're interested in are patients with myelopathy or those with acute spinal cord injury. How do these two pathologies change or influence the results of the physiology? Wanted to understand how the relationship between radiographic presentations and electrophysiology are. So the most basic of this is just looking at the reduction in area of the cord. Okay, so how does compressive pathology, how does the compressed cord with or without T2 signal indicating myelomalacia, and where is that myelomalacia? Okay, what part of the cord is being affected by injury, and is this having an effect on the physiology? And then finally, of course, importantly, what's the effect of surgical decompression? And we know that surgical decompression is a treatment that is effective for spinal cord injury and for myelopathy. But we don't really understand exactly how that's affecting the physiology and the signaling through the spinal cord. Then, of course, the second part is the actual neuromodulation. And we have not approached this yet. We have not done this yet. So I don't want to talk too much about it, but that's where we're headed to epidural stimulation, but to really pair brain and spine stimulation to change motor function. And we want to do this, and we wanted to do this both in patients with chronic spinal cord injury, so cervical myelopathy, as well as acute spinal cord injury, the goal being to improve recovery of arm and hand function. Okay. So this is the pathology that we're looking at. Well, I'm not talking about acute spinal cord injury. We're only going to focus on myelopathy because those are the patients that we have had access to and that we are doing. We've had a chance to run some of our protocols in. And it's an incredibly complex pathology. We know that the mechanism, that there are contributions from static, so just frank compression, dynamic movement of the cord in the vertebral column, so buckling of the ligament flavum during extension, transient compressive events, patients who are kyphotic, who have large ventral osteophytes, who aren't frankly compressed, but who move their cord over this repetitive percussive insult to the cord can cause a myelopathy and, of course, ischemic injury. And then, this is a combination probably of upper and lower motor neuron, or, if we want to call this myeloradiculopathy, but the bottom line is with respect to the upper motor neuron injury, this is primarily the long tract. So the corticospinal tract, spinothalamic, the dorsal columns, and the spinocerebellar. Oftentimes it's the gray matter disease. We see this with the myelomalacia hallmark injuries that we see on MRIs. But there's also a component of white matter disease, particularly the medial aspects. And then we don't really know at the level of cell damage. Is this affecting interneurons? Why do we have spasticity and hyperreflexia? A lot of concepts, a lot of ideas about what's gone on from a pathophysiology standpoint. But there are still a lot of questions with respect to the injury itself. Okay, so with respect to our methods, these are all patients who are undergoing posterior decompressions for cervical spondylotic myelopathy. Okay, so laminectomy and laminoplasty. We are going to we are expanding. We're in the process of writing an IRB amendment to include anterior procedures because we want to look at patients undergoing ACDF and corpectomies. We don't have that yet. We don't have any data on that. But the patients undergoing posterior laminectomies or laminoplasty are patients that we have access to the dorsal epidural space. And those are the patients that we have enrolled thus far. We have about 15 minutes. We're using handheld bipolar electrodes to do epidural stimulation. And we're not using anything outside of just the standard neuromonitoring technique. So anything that we use to monitor the spinal cord during tumor resections, when we're stimulating screws, when we're doing epidural stimulation, like with D waves, these are all the techniques that we're using. This is all with the standard montage of electrophysiology, all using our standard hardware. So there's nothing out of the ordinary. We're just changing some of the protocols that we're in the ways that we're doing this. And I'm just going to run through a couple of the procedures here. So it's essentially, this is what it looks like intraoperatively. Handheld bipolar electrode stimulating in the midline. Here we are stimulating laterally. So when we go back and forth to compare between midline and lateral, this is what we are actually doing. We start at the caudal most extent of the exposure. Again, we are very much interested in hand function. So that's where we want to get the most rich data. We start as low as possible. The most common procedure is a C3 to 6 or C3 to 7. So oftentimes we only get down to C7. We'd like to be looking at C8 and T1, but we look at what we have access to. Our stimulation parameters have changed over time, but essentially we're always less than 10 milliamps. We do ramps from essentially 1 milliamp up. We're doing trains of 3 for the most part. These are 0.5 millisecond stimuli in 2 millisecond intervals. This is what it looks like when we go through in terms of just a schematic here. We start down at C8 if we have it. We didn't have it in this patient. We start C7, midline. Okay, that's what the M refers to. We stimulate midline. We find a threshold. Okay, so we find a threshold of stimulation intensity, which gives us a response in the muscle that we're measuring. Okay, and we're measuring all the muscles with every stimulation, but at C7 we would expect to see hands, triceps, biceps stimulate, and once we identify a threshold from the midline, we go and do the exact same thing in the lateral position, and then we march north. And if we look, we try to look lateral at the rostral most extent of the exposure, pending the amount of time that we have. Okay, and when we find threshold, our threshold is essentially defined as the stimulus intensity that will give a motor response 50% of the time. Okay, so here's our stimulation amplitude. This is time 0 from when we start the experiment. We're starting at C7 in the midline. We start low intensity. We start ramping up. We identify our threshold. The amplitude that we then use to stimulate is 120% of our threshold. So if our threshold is 5 milliamps, we'll start stimulating at 6 milliamps, and we'll march north in the midline. And here we're measuring our triceps response. We go to C6 midline. We're just again kind of doing a ramp. This is reversed here. We move to C5 in the midline. Again, we're looking for thresholds. Come back down to C7, confirm. We've identified now a good threshold value. We get to 120%, and now we start stimulating laterally. We know that that's going to give us a good response. Lateral, the cord is more sensitive laterally. I'll show you our data. That's one of our primary findings. So we would go down in intensity to see if we can identify a threshold there. And that's essentially how we've started to identify the segmental and local stimulation characteristics of the spinal cord. So this is the most recent subject we did. I'm just showing this because we've kind of refined the protocol over time. So this top panel is our stimulation intensity. So this is a handheld electrode. This particular exposure was a little bit unusual at C4 to T, or I'm sorry, C7 to T1. We started at 6. We know that our stimulation thresholds tend to be around 3 to 6. We start at 6 here. We collect some data. We move up and we move down. We define the threshold. Once we get that, we move out lateral. So here's T1 lateral, and the way on the left side, the way we identify which side we're going to go to is by looking at our responses. So each one of these points is measuring the response of a muscle group to the location of stimulation. So here we're in the midline at T1. These are the left side muscle groups. These are the right side. We're looking at arms, hands, and feet. So we can see here that the APBs are stimulating beautifully on the left, and the response with respect to the area under the curve. So this is, we're looking at microvolts here, is greater than on the right side. Okay, so that once we see a laterality bias, we are selecting the side that we focus on based on the responses that we get. So if someone stimulates greater on the left, we're going to perform most of our experiments, if not all of our experiments, on the left side. So here we go, T1 onto the left side. We see that our thresholds are dropping. Okay, so we see beautiful stimulation here of the hand muscles. And on the right side, we see nothing, which makes sense, right? Now we're on the left side of the cord. We're not really seeing much stimulation on the left side muscles. Go back to the midline. We go to C8, same stimulation intensity that we identified at the beginning. We see hand muscles stimulating preferentially on the left side and not on the right side. We go C8 midline. We see some good stimulation of hand muscles, but not quite as robust as we saw at T1. This is the midline here. We get out lateral and we see beautiful stimulation. Okay, and of course on the right side we don't see much. These big responses here are in the TA. So this, for some reason, the tibialis anterior, this patient had great foot responses to cervical cord stimulation. We're very much interested in it yet. We haven't really had a chance to focus on that, but we are seeing it, and we hope to learn a little bit more about this. And so essentially all we're doing right now is comparing midline versus lateral stimulation. Okay, this is what the raw data looks like. Okay, so this is the left side of the body. This is the right side of the body. We're focusing, this is the same patient, so we're focusing on the left side. The muscle group is listed in each group of panels. These are right side responses, midline responses, left side responses. This is the level that we're stimulating at. Okay, so this is the very, very small. This is not meant to really quantify. We're just simply looking at where we're seeing responses. And we can see that the lateral response, when we do lateral stimulation, it's much greater than medial stimulation. And that's really holding in the arms and in the hands. Okay, so this patient had really beautiful responses. If we blow up the hands, okay, so we're looking at ADM and APB here. We look at our stimulation at C7, at C8 and T1, and we're seeing significantly larger responses to stimulation at the lateral aspect, which we believe is over the dorsal root entry zone, okay? And we're seeing the same thing in APB. We're also looking at the lower extremities. This is TA, AH, ADP. So our tibialis anterior, adductor hallucis, and the extensor digitorum brevis. So we're looking at these foot responses. I don't have a lot to say about them right now, but we're very much interested in how these very low, we're stimulating right at 120% of threshold, and we're seeing responses in the feet. So that's very much interesting to us. So now to kind of characterize this a little bit more, we're going to zoom in on just one muscle response, and most often this is the triceps for some reason, and we're interested in defining this as well. Triceps are responding very robustly. The traces in blue are our midline stimulation. The traces in green are our lateral stimulation. And if we plot this summary data and we look at the area under curve, and we can identify our threshold values here, we see a significant leftward shift with our lateral stimulation with respect to our medial stimulation. indicating that we have much lower thresholds and much greater motor responses to stimulation over the lateral aspect. Now, here's our summary data. Okay, so these are all of our subjects. We don't quite have 15. We've done 15. Some of them didn't give us any responses, so they aren't included here. There are 12 patients included here. For the majority of the patients, the muscle that we're monitoring here is triceps. Again, the triceps gave the most reliably the most vigorous response. And we're comparing medial to lateral stimulation. And if we plot these, again, green is lateral, blue is medial stimulation. We have a very, very strong bias to lateral stimulation, giving the greater motor evoked potentials, okay, as measured in the triceps. So for our first, this is our primary result that we've identified so far. This has been recapitulated in humans now based on some of the findings that have been identified in models, monkeys, as well as in rats. And we believe that this is largely because we're stimulating over the dorsal root entry zone and recruiting that circuit of the alpha of the sensory afferents to the motor neuron. Okay, so the stimulation near the DRZ elicits a larger evoked potential than midline stimulation, and we have, and this has been a really robust effect for us. There was only one patient that stimulated more significantly based on medial as opposed to lateral stimulation. We're very much interested in that patient, and we'll look a little bit more closely at that. But we only have one, and we think that could represent some sort of perturbation in the circuitry there. So how do we know where we're stimulating? This is obviously a cadaver, and this is what we are in. This is where we think we're stimulating. So we took some photos intraoperatively. We did some measurements. We got this is a post-instrumentation CT scan using the Arrow. We then used the BrainLab software, which fuses the CTs to the preoperative MRIs. Of course, that's very important because intraoperatively, we're in the prone position with the neck flexed for the most part. And when patients are taking MRIs, they're supine with their necks extended. So it's very important to fuse these images so that we can actually get a registry. We put a marker where we are intraoperatively, and then based on that fusion calculation, we find out where we are on the MRI. And for a couple of the patients that we've done, we are exactly where we think we are, if not slightly more lateral to the dorsal root entry zone, as opposed to where the medial stimulation is. Medial stimulation, of course, being quite easy to identify. So this was some of our, just a validation for ourselves. So this is this analysis here is based on the same thing. Okay, this is medial versus lateral stimulation. And now we're looking at at stimulation performed at the C4 level. So the vast majority of these patients have T2 signal somewhere C4, 5, 6, or 7, okay? And it's all this mid-subaxial cervical spine. That's generally where the degree of greatest compression is and where the spinal cord injury is. So here we're looking at stimulation at C4, and we're measuring the triceps muscle. So we're going back and forth between lateral and medial, and we find that largely this effect is preserved regardless of the injury. So lateral stimulation remains at a lower threshold, greater amplitude than medial stimulation when we're stimulating at a site rostral to a muscle group that we're measuring according to just standard recognized myotomes. Okay, and we're not sure exactly what this is getting at, but this relationship of stimulation lateral versus medial tends to be extremely robust and very well conserved in spite of really significant injuries to the cord. So the circuitry responsible for that, it remains intact. And finally, I just wanted to, this is some of the work we're doing now. We're using this program called Spinal Cord Toolbox. It's free firmware that our one of our postdocs is getting very much involved with, and Jake Goldberg has also been helping us with this part of the project. Essentially, it allows us to calculate cross-sectional area in reduction. And we've gone through and looked at these and really tried to quantify how compressed the cord is. We're still working on the kinks of this. As you can see, the outlines and the axials need a little bit of attention, but we're trying to automate this so we can standardize it, the extent of compression, and then look at local stimulation. So stimulation at the C5 level or the C6 level, and see how this is affecting the responses at each muscle group. And our results are pretty mixed right now. We have certainly seen some patients like this one, where if you look at the C5 level, that's marked here, this is really the extent of greatest compression, C5. And when we stimulate locally here, we see a marked decrement in the response. You can see bicep stimulation when you're stimulating at C4 and at C6, but at C5 itself, we see attenuated actually biceps and triceps stimulation. So that's the sort of thing that we're looking at with respect to correlating the physiology with the radiographic findings. This is this part of the story is a long way off. So of course, a large part of the mapping is to identify some of those goals that we talked about earlier, but it's also to inform our decision-making about how to set up the threshold of the experiments for plasticity. And again, we want to pair motor cortex stimulation with cervical spine stimulation. Now, importantly, we're going to we stimulate right at threshold. Okay, so we come down to right at threshold, maybe 110% of threshold. But the spinal cord stimulation will be sub-threshold. So we're going to stimulate at about 90% of threshold. And that's based on some preliminary data that was performed in animal models by Jason and others. And we're going to look at the timing and the location of stimulation and see whether or not this has see whether or not this is able to augment the motor responses. And again, we're going to pair this. We believe that this is occurring through an afferent mediated circuit. So we're going to look at that. We're going to compare dorsal versus ventral stimulation. One of the ways that we can get to that. We're going to look at whether or not this can cause a persistent effect. And again, the ultimate goal is to augment spinal excitability and to diminish hyperreflexia. The hyperreflexia story is also evolving. I don't have a whole lot to say about that right now, but it's part of what we're looking at, particularly in patients with chronic spinal cord injury. This is just really illustrating. This is one of our sketches. Basically in our meetings, this is the protocol. It keeps evolving. We try to have a very, very solid game plan before we even get in there as to how we're going to use the 15 minutes that we have for experiments. This is how we're going to perform our paired stimulation. We just got a new amplifier from Cadwell, the IOMAX, that we've been performing some of our experiments on to validate it, make sure it's working the way we want to. We've been working very closely with the IOM team, of course, and Steve Karszewski. Here are some of our recruitment curves. Sorry for this is a very raw data, of course, but part of this is we're going to use trains of 3 with the transcranial stimulation, but with the spinal stimulation, in order to ensure our time lock, we have to get down to a single pulse. And this was just validation that our recruitment curves with trains of 3 versus single pulse, shown in the red diamonds, very much overlap. So we do think that this is going to be feasible. And here's our future directions. Yeah, so cervical spinal cord mapping, we're well underway with this with respect to where stimulation is most effective. defining circuitry with respect to both the medial lateral organization as well as the segmental organization, and defining, there's clearly more real estate dedicated to certain muscle groups than to others. Cervical spinal cord socioplasticity, that's our, we're on the verge of undertaking these. The effect of chronic cord compression versus on motor evoked potential. So that's going to be a part of our imaging wing. We want to go from just cross-sectional area to some more sophisticated forms of MRI, like diffusion tensor imaging, and looking at the long tracts and seeing specifically where these injuries are occurring, correlating them with the electrophysiological responses. Of course, we want to look at the effects of decompression. We really need to understand what we're doing in surgery with respect to decompressing the cord and how that's changing the electrical responses, how it's preserving it. We're certain that we are preventing more injury from happening if that injury is from compression, but we're not exactly sure what we're doing on an electrical level, despite it being really the gold standard of treating this type of pathology. We're very much interested in acute versus chronic spinal cord injuries. That's on the horizon. And then, of course, comparing non-invasive stimulation, so transcutaneous, transcranial magnetic, to invasive, which is epidural stimulation. And we have a partner who we work with quite closely, Noam Harel. He's up at the Bronx VA and Sinai. So here's a team. Of course, this is a huge multidisciplinary effort. Jason Carmel, formerly at Virk when we started. He has since transitioned to Columbia. We have a very talented postdoc, James McIntosh, who's been helping us a lot. He's a modeler and does a lot of code, extremely talented. Steve Karszewski, I think everybody knows him here. He's one of our IOM team from the Department of Neurology. And of course, Oleg and Eugene, who have really been instrumental in working through some of these protocols and helping us out intraoperatively. Noam, I didn't really talk about this, but of course we're trying to compare the effects of invasive epidural stimulation versus some of the non-invasive techniques. We can do a lot with the non-invasive that we can't do with the invasive. So that partnership will be very important. And our own Jake Goldberg, who's been really helpful in doing some of the imaging and interfacing with James. Then, of course, the home team, Dr. Stieg, Hartle, Caplet, starting as a PGY6, trying to get some of the, establish this relationship, put the opportunities into place to make some of this, these collaborations, and just going to great lengths to be supportive, getting this translational effort off the ground. I really want to thank all three of them for being extremely helpful and dedicating a lot of time and advice to this. So happy to take questions. I know we're running towards the end of time, but thank you all for being here and listening.
Hey, thanks, Mike. This is Dan. It's an amazing talk and phenomenal work that you've done. I had a question. When we do transcranial motor evoked potentials, sometimes the monitoring people, when there's just radiculopathy, there's absolutely nothing wrong. So, we can't get triceps data, we can't get hand data, and then before you do anything after you prep and drape, they say, okay, now we got hand data, or they don't have it when they do the anterior, and then we flip over posterior. We haven't done anything differently, and now they can get data or they can't get data. It fluctuates intraoperatively in maybe, 5 or 10% of the cases. And how do you account for that when you're doing your experiments? Do you have variability in the data, or is it better because you're doing direct transdural stimulation as opposed to transcranial?
Yeah, Dan, it's a great question. Obviously, you've been doing this for a long time, and you know how variable. This is human data. We're under anesthesia. We've got a tremendous number of variables. Even in the best case scenario, we just can't control for all of these things. So it's hard to, some patients. The patients that I wasn't showing there is because they just don't have any responses. These patients they have such severe pathology, they don't have any responses. And there's no two ways about it that some muscle groups are more injured than others. And when we do different things with positioning, it's tricky because positioning clearly has an effect on our responses. You know, when we flex or extend muscles and then we stimulate, and we can do some of these experiments in the non-invasive groups, right? So if you put muscle groups in different positions, you will definitely change the responses. The number of variables that influence monitoring are so great that we are constantly taking baselines and then going back to do the experiments. And you know, there's probably less variability with epidural stimulation, because as you cut out synapses and as you cut and you get more and more direct, you're going to see more robust responses. For example, as you know, with spinal potentials, if we're just looking at D waves, that's a very robust signal. That's an incredibly robust signal. It's why a lot of people, you know, it's really the gold standard for some of these intramedullary tumor resections, because when that starts going down, and that gets below 50%, we're probably affecting the motor pathways in a real way. Whereas with motors, we don't always know whether or not the signal is real. So it's a great point. It's something that we are constantly keeping in mind. It's very difficult to control for. We're constantly taking, you know, baselines to go back to compare. And there's no way you can do an experiment and then 3 hours later do that exact same experiment and compare the two without getting a new baseline, right? I mean, it's too variable. So really important to keep in mind. And there's only so much we can do.
Thanks.
Mike, great work, fascinating work. Also, you know, that you got this IRB approved to do in patients. You know, I can only imagine how difficult that must have been, but great data. Can you just expand again? What are the theories behind the combination of the transcortical, transcranial stimulation and the transdural spinal cord stimulation being more efficient than either one of those alone? Because at the end, they all work, you know, they all converge right on the same spot.
Right. So we think that there is some sort of potentiation taking place somewhere along the circuitry. So we think that this is really a learning or a potentiation. You know, there's synaptic plasticity that's occurring that we can measure in the short term by doing this, right? So the convergence. So generally, you know, it just goes to the basics of neurophysiology. Neurons that fire together wire together, right? So if we fire
thoughts about something.
I'm sorry?
Oh. Did you want to cancel the surgery?
Oh, hey guys, can we mute a little bit if possible? Anybody who's not muted. So if we converge the corticospinal tract, firing from activation of cortical motor neurons with input from a sensory neuron through that same arc on that same motor neuron, we think that that's what's causing the potentiation. And it doesn't last permanently, but it does last for some time. In terms of what is happening at the synaptic level, that's going to have to be a question that we ask in animal models, brain slices, cell culture. That's what those experiments are really good for, really teasing out the molecular mechanisms, what's actually happening at the level of the synapse. How are the channels changing? How are the receptors changing? What second messenger systems are being augmented? I mean, there's a ton going on, but we're trying to see what is actually happening at the big picture, at this level of circuitry, and then kind of dive back down, and that's how these questions just have to be answered. With respect to the IRB, we're working on a single institution IRB, and that is perhaps the biggest challenge that's going on right now. We've also applied for a grant. We've got a great score, and we're waiting to hear back on a multi-site R01. So hopefully that will all go in the way we want it to, and we'll be able to increase our volume by pairing up with our Uptown team. So this would really be a multi-site, multi-institution collaborative initiative.
Michael, is that okay, Roger, if I ask a question?
Sure, please.
So 2 things, Michael. First, with respect to IRB, I share your enthusiasm and the obstacles that have been put forth, but I understand that is moving in a very positive direction. So more to come, and I do think that's an amazing capability that we have on both campuses. So congrats. The question I have has to do with mapping of the dorsal columns. You didn't touch upon this, but for the intramedullary tumors or intramedullary pathology, you and I have partnered on several of these cases. There's been some talk about utilizing somatosensory evoked potentials to map out the median RAF-A, looking for what essentially is a phase reversal. I think that requires some modification of the electrodes we're using, microelectrodes that are sub-millimeter scale. Do you know if we have that capability here? And if not, could we speak to our EP people about tailoring some of these electrodes to do just that?
Yeah, I think, so there are a couple questions there, and I think that the best, the finer the electrodes, right? The more points you have, the more resolution we would get. So if we could put down a 100 electrode array right over the middle, I think that we could very, very easily do that. Now, is that approved for? I've never seen anything like that. That's all in the realm of experimental, animal sort of electrodes. And there are some, of course, that you can use for human brain study, but in the spinal cord, I don't know that we have anything of that resolution. We could put down something that's more coarse, like the finest paddle electrode that we could find to map out the median RAF. I think it's a great project for it's a great application of monitoring, and I would have to look into it to see. I don't think that we have that sort of electrode on the shelf. We have a lot of great electrodes, but I don't think we have that one. But I would envision something that you could actually put on top of the cord and leave it alone, not move it around, and then find out between which electrodes do we see reversals, and then based on that, if it had markers on it, we could find the median RAF-A, as opposed to just doing hand stimulation. We could do that in addition, but that would be very helpful, because doing it visually, as you well know, is always quite challenging, or can be quite challenging.
Yeah, I'll forward you a couple of references that actually have done just what you're proposing. But again, all those require modifications based on pre-existing or commercially available arrays. So I'd value your input on this, whether or not we can devise similar types of electrode arrays.
Yeah, I think if it's commercially available and FDA approved, our IOM team has been very dynamic. I think we'd be able to get that in, Mark. Let's talk about that.
It's great. Thank you.
Well, Mike, this was a great presentation, good discussion. I personally would have a million more questions, but